Okay, picture this. You're in the NICU. A newborn who seemed perfectly healthy just yesterday is suddenly lethargic, not feeding well, and breathing way too fast. Labs are pending, but you've got that sinking feeling. This is metabolic and it's not going to wait. So, let's dive right into this exact scenario, because what you do in the next couple of hours can literally change a life. This is it. This is the classic presentation that every resident, fellow, and attending absolutely dreads. A baby who is totally fine just hits a metabolic wall. This isn't just a run-of-the-mill sick infant. You've got to be thinking about an inborn error of metabolism, and one of the most urgent on that list is a urea cycle disorder. So here's our game plan to tackle this. First, we're going to get to know the body's detox engine. Then we'll see what happens when that system fails. After that, we'll decode the diagnosis step by step. We'll walk through managing the crisis in the NICU, and finally, we'll touch on what life looks like after that initial storm has passed. All right, first things first. To really understand the disease, you have to appreciate the elegance of the machine that's broken. The urea cycle, it's not just some obscure pathway you had to memorize for an exam. It is one of the most vital, life-sustaining detoxification engines in our entire body. The easiest way to think about it, it's like the liver's own specialized water treatment plant. Every single time we eat protein, our body breaks it down and, as a byproduct, creates ammonia. And let me be clear, ammonia is poison, especially to the brain. So the urea cycle is this amazing multi-step process that grabs that toxic ammonia and chemically transforms it into urea, a totally safe compound we can just get rid of in our urine. And here's that beautiful engine in action. It all kicks off inside the mitochondria. Ammonia gets combined with bicarbonate thanks to an enzyme called CPS1. Then, our next enzyme, OTC, steps in and makes tritulene. This tritulene then gets shuttled out into the main part of the cell, the cytosol, to continue its journey. It goes through a few more reactions, and finally, an enzyme called ARG1 cleaves off urea, and, this is the key, it regenerates the starting material so the whole cycle can begin again. It's just this perfect, continuous loop. But what happens when there's a glitch? When one of those critical enzymes is defective? Well, the entire detox engine just grinds to a halt. And the consequences? They're devastatingly fast. This is the classic and, frankly, chilling presentation. You see, at birth, the baby's fine. Why? Because mom's placenta was doing all the work, clearing the ammonia. But as soon as the baby starts taking protein feeds, that ammonia starts to build up. This is what we call the lucid interval, a terrifying false sense of security before the crash. The first signs are super nonspecific, poor feeding, maybe some fussiness, but they escalate fast. So why is ammonia so incredibly toxic? Well, it zips right across the blood-brain barrier where it's taken up by brain cells called astrocytes, causing them to swell up like balloons. This leads to cerebral edema, swelling of the brain. The pressure on the brainstem initially triggers hyperventilation, which causes a really characteristic respiratory alkalosis. That's a huge clinical clue. But as that pressure gets worse, it leads to respiratory arrest, seizures, coma, and if you don't act fast, death. What's really cool is we can actually pinpoint exactly where the failure is. Let's look at a blockade at OTC, which is the most common UCD. As you can see, when OTC fails, the cycle gets stopped dead in its tracks right after step 1. You get this massive backup of the stuff before it, while ammonia levels just skyrocket with absolutely no way forward. Okay, so what happens if the block is a little further down the line here at ASS? Well, ammonia still builds up, for sure, but now the cycle traps all that waste nitrogen as stritulene. So unlike the low stritulene we see in an OTC block, here we see massively elevated levels. And that is a crucial diagnostic clue that points you right to the broken enzyme. And you're probably seeing the pattern now, right? A block at the very next step, ASL, causes a buildup of its specific substrate, this argininosuccinic acid. It's amazing, really. Every single enzyme defect leaves its own unique biochemical fingerprint in the blood or the urine. Our job as clinicians is to know how to read those fingerprints to make a super rapid diagnosis. So the baby is crashing. You're pretty sure it's a UCD. Now what? How do you go from just a suspicion to a specific diagnosis right in the middle of a crisis? This is where your clinical workup becomes your absolute best friend. I mean, let's be honest. All these babies present with high ammonia, and they're encephalopathic. So how in the world do you tell the difference between a CPS1 defect and an OTC defect when literally every single minute counts? The answer is in just a few key lab tests. This algorithm right here. This is your roadmap in a hyperammonemic crisis. The first and most important question is about the plasma amino acids. Is citrulline low or basically absent? If the answer is yes, you're looking at a proximal defect, something like OTC or CPS1. Is citrulline through the roof? Then you're probably dealing with ASS deficiency. Following these branches just leads you right to the answer. Okay, so let's boil it all down. If the plasma citrulline is low, you need a urine orotic acid level, and you need it stat. Why? Because in OTC deficiency, all that backed up material spills into a different pathway and produces a huge amount of orotic acid. But in CPS1 deficiency, that starting material is never even made, so the orotic acid is normal or low. This one test is the tiebreaker. It can differentiate the most common and the most severe UCDs. Okay, you've got your working diagnosis. Now the clock is absolutely ticking. You've got to get that ammonia level down before irreversible brain damage happens. This is an all-hands-on-deck, true medical emergency. Your first 3 moves are immediate and totally non-negotiable. First, stop. Stop all protein, whether it's breast milk, formula, whatever. You have to turn off the faucet of ammonia production. Second, reverse. You've got to reverse the body's catabolic state with high dextrose IV fluids. A body that's breaking down its own muscle is just releasing more ammonia. Third, provide. Give enough non-protein calories to push the body into an anabolic or building state. Next, we have to open up some alternative escape routes for all that nitrogen. That's where scavenger drugs come in. Think of them like chemical sponges. They bind to amino acids and allow the body to get rid of nitrogen waste without using the broken urea cycle. At the same time, we prime the pump of what's left of the cycle with IV arginine, which can help drive the later steps forward and use up some of that waste. Yeah, you've got to pay very close attention to that ammonia level. Any elevation is a big deal, but a level above 200, and definitely anything getting close to 400, that's a huge red flag that medical management alone might not be enough. This is a really critical threshold. And this brings us to probably the most important decision you're going to make. If that ammonia level is profoundly high, or if it's not coming down with the scavenger drugs, you cannot wait. Hemodialysis is, without a doubt, the single most effective and fastest way to clear ammonia from the blood. It is life-saving, and your threshold for starting it should be really, really low in a crashing newborn. Okay, so you've gotten them through the crisis, but surviving that initial event is really just the beginning. Managing a urea cycle disorder is a lifelong journey. It takes a whole team and a deep understanding of that patient's specific defect. For most UCDs, the game plan is simple: a strict, low-protein diet for life. But, and this is so important, there's a fascinating and critical exception: citrine deficiency. Because their defect involves a transporter, these patients paradoxically do better on a high-protein, low-carb diet. It's wild. They often develop a natural aversion to carbs on their own. It's a crucial distinction you have to remember for long-term care. So let's just do a quick recap of the absolute must-know points. You see a newborn with neurologic decline and that classic respiratory alkalosis, you have to think UCD. Get an ammonia level immediately. While you're waiting, stop protein and start a D10 infusion. Call your metabolic team. Use plasma citrulline and urine orotic acid to figure out which one it is, and most importantly, if that ammonia is dangerously high, do not delay, escalate to hemodialysis. You know, with aggressive and timely intervention, we can save these children's lives. But the length and the severity of that initial hyperammonemic event, it can leave lasting scars. So the ongoing challenge isn't just about preventing the next crisis. It's about optimizing their neurocognitive outcomes and truly understanding the long-term price of surviving that initial toxic flood.